team a little bit more, and then we'll start to talk about how we're managing methamphetamine use disorder at the Owen Clinic. So I'm Laura Bamford, and I'm actually the medical director at the Owen Clinic, but also have clinical interest and expertise in the intersection of substance use disorders and HIV treatment and prevention. I'm joined by Amutha Rajagopal, who also has a passion for taking care of individuals with substance use disorders, is also an infectious disease specialist like myself, and works here treating patients in our HIV primary care clinic. Dr. Montoya is a psychologist in the Department of Psychiatry here at UCSD, and she's also an expert in substance use disorders, and particularly the evidence-based treatments of cognitive behavioral therapy and contingency management. And then Vernay Justice Royster is our amazing behavioral health counselor. We wouldn't be able to do this work without her. She sees many of our patients, does some brief counseling here at Owen, and helps really whatever they need on their path to recovery. And likewise, Damon Robinson, who is the last to join our group, but we're so excited to have him. He's a recovery specialist here at Owen, and in conjunction with Vernay, really supports our patients, whatever they need, really meets them where they're at on their path to recovery. And again, this is our team. One additional person is Samantha Yeager. She's a postdoctoral scholar here at UCSD, and has been helping us with some research studies here at the Owen Clinic. A little bit more about the services that we provide. So we do have 3 providers who are dedicated to prescribing medication-assisted treatment, and that is myself and Dr. Rajagopal, but also Dr. David Grillotti, who is a psychiatrist here in the Department of Psychiatry, and is integrated into the Owen Clinic, so does both MAT, but also general psychiatry for our patients living with HIV and at high risk of HIV. And the MAT that we prescribe is for opioid use disorder, methamphetamine use disorder, and alcohol use disorder predominantly. As I mentioned, Damon and Vernay also do some substance use counseling. They also work with patients to refer them to inpatient and outpatient substance use disorder treatment programs here in San Diego. And we also offer a bunch of harm reduction services. So the prescription of naloxone to our patients, the prescription of clean syringes and needles when necessary. We refer folks to the syringe service programs in San Diego. We do a lot of education on fentanyl and its adulteration of the substances that patients may be using. And we also other education on not using alone. So a lot of harm reduction in addition to our other services. And then finally, we're offering contingency management and cognitive behavioral therapy, which Dr. Montoya will speak about later. Right now, mostly in the context of research studies at Owen, but we hope to expand access to those evidence-based therapies for our patients. So the reason, one of the reasons that we're all doing this work is because in 2020, the United States saw the largest number of overdose deaths in its history, with close to 92,000 deaths. And then that was surpassed in April 2021 with over 100,000 deaths in the preceding 12 months. And that represented almost a 30% increase from the previous year. And as you all know, this exponential increase in deaths is largely driven by synthetic opioids other than methamphetamine, primarily fentanyl. But something else to note on this graph is that in 2019, psychostimulants with abuse potential, which are primarily methamphetamine, surpassed cocaine in the number of overdose deaths in this country. And if you look at the distribution of opioid and stimulant involvement in drug overdose by geographic region in the U.S., as you move from the Northeast across to the West, one, you can see that opioid deaths, do make up the largest percentage of overall deaths. But as you move west, again from the Northeast to the West, those top bars, stimulants, so mostly methamphetamine, make up a larger percentage of overdose deaths. So here in California, we see far more deaths related, just directly related to methamphetamine than they do on the East Coast. And because we are the HIV clinic at UCSD, we are also concerned about the impact of methamphetamine use on HIV treatment and prevention. And persistent use of methamphetamine was found to be the biggest predictor of HIV seroconversion among MSM in the United States. And this comes from this ongoing nationwide internet-based cohort called the Together 5,000 study. And in fact, MSM who use methamphetamine are at 7 times higher risk of HIV seroconversion compared to MSM who do not use methamphetamine. Rates of persistent methamphetamine use, as I mentioned, are highest in the West. So this is particularly a problem here in California amongst our men who have sex with men, and that compares to rates of 9% in the Southeast, 7% Midwest, and 5% in the Northeast. And MSM who use methamphetamine are more likely to have condomless sex with partners without HIV or of unknown serostatus, and are less likely to be virally suppressed. And a little bit about the demographics and the changing demographics of methamphetamine use in the United States. So first of all, this from a clinic-based survey of people with HIV in San Francisco, they found that 20% of the MSM in their patient population, 16% of the heterosexual men, and 15% of the women reported methamphetamine use in the previous month. So very high rates. And then a cross-sectional study which analyzed data from the 2015 to 2019 National Survey of Drug Use and Health found that participants who reported using methamphetamine disclosed higher risk behavior over time. So meaning that when they started using, they were more likely to be smoking or snorting methamphetamine, but over time switched the method of use to injection. And that really corresponds, I think, to the increase in overdose directly related to methamphetamine with riskier use over time. And the study also showed that methamphetamine use during that 4-year time period diversified to populations that were not known for prevalent use. Methamphetamine historically has been a substance used mostly among middle-aged white MSM, but in this study, where they found that use doubled among MSM, it also more than doubled among heterosexual men and more than tripled among women. And the study also showed a 300% increase in very young people, which is alarming, those 18 to 23, and a 10-fold increase amongst Black persons. And there's a little bit of the data from the Owen Clinic. So when we looked at this recently, about 16% of our patient population has used methamphetamine in the past 12 months. And the way that we estimated these numbers was based on either having a urine drug screen that was positive for methamphetamine in the past 12 months, or an encounter diagnosis. So they saw a provider at the Owen Clinic, and in like the billing encounter, they used methamphetamine use disorder as a billing encounter. So this may underestimate, the overall use at Owen if providers didn't document this, or patients didn't have a urine drug screen, or even if we haven't seen patients in the last 12 months. That I think that 16% is quite an alarming number, and I think consistent with what the clinic in San Francisco demonstrated in the previous study that I mentioned. 88% identify as male of our population that uses methamphetamine. About 55% identify as lesbian, gay, or bisexual. The median age was 46. Largely it's still used largely amongst people who identify as white. We did see 12% use amongst individuals who identify as Black, which is higher than our overall patient population of about 7% who identify as Black. Our Hispanic patients were a little bit underrepresented in use. They made about 29% of patients who use methamphetamine in our clinic, but about 33% of our patient population. All right, and then a little bit by HIV transmission risk factor. So about 50% identified as MSM. And then what was interesting is that about 84% of patients who use methamphetamine were virally suppressed. So about 15% who were not. And that corresponds to our overall clinic population that has a 94% viral suppression rate. So clearly, it looks like methamphetamine, may be inhibiting people from taking their HIV medications the way they should and remaining virally suppressed. Most of our folks had very high CD4 counts, but 10% had low CD4 counts, and that's actually higher than our overall clinic population. Lastly, we looked at each hepatitis C antibody positivity as a marker of sharing injection equipment. And we did not see higher rates compared to the overall population of people living with HIV who are co-infected with hepatitis C. So only about 17% of our population had a positive hep C antibody. That corresponds to about 20% of overall in the United States. So perhaps our patients, who are using methamphetamine, even if they're injecting, aren't sharing equipment at higher rates than would be expected in the general population. And then one other thing we looked at, and Dr. Rajagopal will be talking about medication-assisted treatment, but some of the things that we've used at Owen include mirtazapine, bupropion, and naltrexone. And I just, our data analyst just looked at, of all the people with methamphetamine use in the last 12 months, how many, are prescribed mirtazapine or bupropion or naltrexone, and it's about 46%. So we are getting medications to these patients for treatment, but we could, do far better, I think, in reaching more of our patients who need these meds. And then finally, I just wanted to talk just briefly about a study that we recently started at the Owen Clinic. This was with funding from the National Institutes of Health through the Center for AIDS Research here in San Diego. And the aim of this study was to characterize our population here at Owen, which I've done in the previous slides, but really based on that study that looked, that 4-year study that looked at the changing demographics nationally of people who use methamphetamine, and we really wanted to characterize what our population looks like here at Owen. So we're, that's some preliminary data that I showed you, and we're still working to more accurately characterize that population. And then our second aim was to assess the feasibility and acceptability of integrating the behavioral therapies for methamphetamine use disorder, contingency management, and cognitive behavioral therapy, which Dr. Montoya will speak about later. So integrating these into HIV primary care by measuring program adherence. So the proportion of completed therapy sessions out of the 24 total possible sessions, We're looking at retention in the program, so the proportion of participants who are retained over the 12-week program, and also treatment effectiveness. So this isn't a clinical trial. We're not looking at efficacy, but just looking at urine drug screens over time, and urine drug screen positivity for methamphetamine over time, and to see if that does decline. And then finally, at the end of the study, we're assessing participant satisfaction with integrating these behavioral therapies into the Owen Clinic by administering the treatment perceptions questionnaire. All right, and so I'm now going to turn it over to Dr. Rajagopal, and Dr. Rajagopal will ask me to advance her slides.
Yes.
All right, so go ahead, Amu.
Good morning, everyone. Thank you for this opportunity. I'll be presenting an overview of studied pharmacologic therapies for methamphetamine use disorder. Next. So before I talk about medications, I will briefly overview the biological activity of methamphetamines. So methamphetamine is a synthetic psychostimulant that increases the levels of monoamine neurotransmitters, which include serotonin, dopamine, epinephrine, and norepinephrine. Methamphetamine primarily affects our dopamine systems, and the mechanisms by which it increases the levels of dopamine are many, but include one, increasing both the expression and the activity of tyrosine hydroxylase, which is a critical enzyme in the synthesis of dopamine. Methamphetamine also decreases the reuptake of dopamine from neural synapses by reducing the expression of presynaptic transporters and also blocking their activity. Methamphetamine also inhibits the breakdown of dopamine by inhibiting monoamine oxidase. So the main effect of all of these processes and more is dopamine becomes highly concentrated in the synapses and in central nervous system pathways that regulate motivation and our experience of pleasure as well. Next. So most studies examining pharmacologic therapy for stimulant use disorders in general have examined cocaine use. And while cocaine and meth have similar mechanisms of action, there are major differences that may require different therapeutics. So the reinforcing properties of cocaine are mediated primarily by blockage of dopamine reuptake, while effects of methamphetamine are by both blockade of reuptake as well as increased presynaptic synthesis and release of dopamine. Cocaine is also much more quickly removed from the body with a shorter half-life of about an hour compared to the prolonged presence of methamphetamine for several hours. Next. So no medications have been shown in randomized clinical trials to be consistently efficacious for stimulant use disorders in general, and there are no currently FDA-approved pharmacotherapies for methamphetamine use disorder. Some limitations of the existing research include that most studies have looked at abstinence and not reduction in stimulant use as an outcome. Adherence severely complicates the existing studies on therapeutics in general, encouraging more research on long-acting treatments. Only psychosocial interventions, which will be discussed soon, specifically have been proven to be consistently helpful for stimulant use disorders, including methamphetamine use disorder, while we know that they are insufficient for many individuals. Now I'll go through the evidence for pharmacologic options that have been studied. Next. So first, because it is a common question and consideration among patients, I'll discuss a little bit about dopamine agonist therapies, such as long-acting amphetamine and methamphetamines for stimulant use disorder. So this would be analogous to using methadone for the treatment of opioid use disorder. These options would be less abusable due to slower uptake and longer duration of action. But studies regarding dopamine agonist treatments for stimulant use disorder have largely included subjects who use cocaine and have had mixed results in terms of benefit. Nearly all studies have had high dropout rates with less than 50% retention. Next slide. I included here a more recent trial with a higher retention, which found dexamphetamine sustained release to reduce days of cocaine use specifically, which is promising, but more studies will be needed for this. Next. So other pharmacologic treatments that have been considered for stimulant use disorders include modafinil, which is used to treat narcolepsy and blocks dopamine transporter. It has shown initial promise for cocaine dependence in a small trial that has not borne out in larger trials, however. Other medications listed here that have had some potential benefit, at least for cocaine use disorder, are disulfiram, vigabatrin, and topiramate. And a vaccine has also shown mixed results in the treatment for cocaine dependence called TACD, which stimulates production of cocaine-specific antibodies that bind to cocaine molecules. Options that have been studied more specifically for methamphetamine use disorder with mixed results include bupropion, naltrexone, mirtazapine, and bupropion in combo with injectable naltrexone. And so I'm going to spend the rest of the talk discussing these in more detail. I also included buprenorphine here, which was studied in a small randomized controlled trial of 40 men and was found to at least significantly reduce reported cravings to using methamphetamine compared to placebo in one study. And then on the right, so monoclonal antibody-based medications designed to bind methamphetamine with high affinity are among the newest approaches to treatment. And so these treatments would actually target methamphetamine instead of central nervous system networks of receptors, like small molecule agonists and antagonists that are currently used. And antibodies with unique antigen binding fragments could also be used for specific clinical indications, acute and chronic. So the response from infusion of a monoclonal antibody could be both immediate and long lasting, which would make it feasible to treat both a drug overdose by targeting methamphetamine itself, as well as chronic drug addiction due to longer elimination half-lives of monoclonal antibodies. A person's motivation to use methamphetamine may fall if the antibody decreased the immediate effects from methamphetamine, including the immediate and intense high. And these antibodies could also have less abuse liability than dopamine agonist treatment might. One of the major disadvantages may be the possibility of an allergic reaction to the protein. And so it would be important to assess for that, of course, and also to ensure no significant cross-reactivity of monoclonal antibodies with other medications or neurotransmitters. At present, a monoclonal antibody called IXT-M200 has been studied in vitro and in animals and was approved by the US FDA for testing in people in 2013. Results from the phase 1 trial, which assessed for adverse reactions, were actually encouraging. No volunteer among 42 participants who do not use methamphetamine suffered any serious adverse reactions to the antibody. Phase 2 clinical trials test whether new medication produces the proposed therapeutic pharmacologic effects in humans. And preliminary data suggests that IXT-M200 efficiently binds methamphetamine in the blood in people who do use methamphetamine. There's a lot left to go in completing all the steps that the FDA requires for approval, but we may be just a few years away from having such a treatment option on the market. Next slide. So now back to existing treatment options. Bupropion monotherapy has had mixed results. Bupropion is a dopamine and norepinephrine reuptake inhibitor that has been shown to be helpful for efficacious for major depression and nicotine dependence. By increasing dopamine synaptic activity, it may alleviate stimulant withdrawal symptoms. Next slide. So in one 12-week randomized double-blind placebo-controlled study, 300 milligrams of bupropion daily was compared with placebo in about 150 patients with methamphetamine use disorder. Retention was around only 50% in each arm. The primary outcome measured was the proportion of participants that had a methamphetamine-free week based on multiple urine drug screens. And no statistically significant difference was found in the primary outcome between groups. However, a non-significant trend favoring bupropion over placebo was found. Next slide. A subgroup analysis in the same study showed that bupropion did have a significant effect, however, specifically among those patients who had a lower level of methamphetamine use at baseline. Next slide. So two other studies have looked at end of treatment abstinence as an outcome with bupropion in a 12-week program with about 200 subjects that were randomized to 300 milligrams daily bupropion or placebo. Again, they did not significantly differ in the proportion of people achieving abstinence. And in this study, the subgroup analysis of participants with lower baseline methamphetamine use also revealed no difference in abstinence. Medication adherence, however, was found to be poor, with less than 50% of participants actually adhering to bupropion. And then one more study that evaluated end of treatment abstinence demonstrated no difference as well between bupropion 300 milligrams daily compared to placebo. However, end of therapy abstinence was significantly higher in those participants who were actually adherent to bupropion, determined by plasma bupropion metabolite levels in this study. 54% achieved abstinence compared to 18% of non-adherent participants. However, medication adherence was generally low among the study subjects, around 32%. So this study suggested that when taken, bupropion may be efficacious for reducing methamphetamine use. Next slide. Another clinical trial suggested that mirtazapine may be efficacious for methamphetamine use disorder. Mirtazapine or Remeron is an FDA-approved antidepressant as well. It's thought to raise synaptic levels of dopamine, also serotonin and norepinephrine in areas of the brain that are involved in drug craving. Next slide. So participants in this small double-blind randomized controlled trial included sexually active cisgender men, transgender men, and transgender women having sex with men who were actively using methamphetamine and had methamphetamine use disorder. Participants were randomized to mirtazapine 30 milligrams daily or placebo for 6 months. And the primary outcome that was looked at was positive urine drug screens for methamphetamine at different time points. Next slide. So 120 participants were enrolled in the study. On average, they were in their mid-40s, mostly white. And a little more than half of these participants had HIV. The most common frequency of meth use that was reported was nearly every day. Next slide. In the intention to treat analyses, the rate of methamphetamine positive urine samples, which is orange in this graph, appeared to be significantly lower among participants assigned to mirtazapine versus placebo at each tested time point. However, as evident in this figure on the left, the vast majority of participants had positive urine drug screens in both arms throughout the study period with some overlap. By week 24, at the end of treatment, positive urine drug screens were in 63% in the mirtazapine arm compared to 74% in the placebo arm. At week 36, 3 months after stopping mirtazapine, 71% in the mirtazapine arm had positive urine drug screens versus 88% in the placebo arm. Next slide. Notably, most high-risk sexual behaviors were reported to be decreased significantly among participants taking mirtazapine compared to placebo, including self-reported number of sexual partners and unprotected anal receptive sex with HIV serodiscordant partners. Next slide. Participants assigned to mirtazapine also had net reductions in reported depressive symptoms and insomnia severity. Next slide. Again, the rates of adherence in the study were poor and were similarly low in both arms, around 40% at 12 weeks, and even lower in the following 3 months of use. Next. End of study abstinence, defined as abstinence from methamphetamine during the last 2 weeks, showed no difference between the arms as well. Next slide. So while there are no currently approved drug treatments, these results indicated that mirtazapine could be helpful for reducing meth use for men who have sex with men, with benefits extending to 24 weeks and possibly longer. It also could be associated with significant reduction in HIV risk behaviors. And then also consistent with its known effects, mirtazapine may help improve depression symptoms and insomnia severity for people with methamphetamine use disorder, which are common. Notable limitations, of course, are the poor treatment efficacy and poor adherence in general, with the majority of participants non-adherent to mirtazapine. But longer acting formulations or paired behavioral interventions may be helpful to study in the future. Next slide. In January of 2021, this article was published in the New England Journal of Medicine, which described the ADAPT-2 trial, which stands for Accelerated Development of Additive Treatment for Methamphetamine Use Disorder. And this was a trial funded by the National Institute on Drug Abuse and evaluated treatment with bupropion in combo with injectable naltrexone for methamphetamine use disorder. Next slide. So again, bupropion has had some evidence for benefit in the literature. Naltrexone is a medication approved by the FDA to treat both opioid and alcohol use disorders, and it comes in a pill form or as an injectable. Next slide. So the reinforcing effects of methamphetamine are principally mediated by stimulation of dopamine in the corticomesolimbic pathways. However, other neurotransmitter systems do modulate brain dopamine, such as the mu-opioid receptors located on the same dopamine neurons. The important functional interaction of the dopamine opioid system is evident from the results of preclinical and clinical studies. For example, in rat studies, chronic administration of cocaine has been shown to actually increase opioid receptor binding in reward pathways of the brain. And increased binding of opioid receptors has been correlated with self-reported cravings for stimulant. Naltrexone is an antagonist or blocker of mu-opioid receptors. And while naltrexone does not interact directly with dopaminergic pathways that meth does, its blocking effects may reduce the pleasure associated with using non-opioid drugs, such as stimulants. Naltrexone has also been shown to modulate dopamine release in the nucleus accumbens and ventral tegmental area in alcohol use disorder. Next slide. So there are a few studies of naltrexone monotherapy for methamphetamine use disorder, which, like bupropion, have also shown mixed results regarding a benefit, while they've also had high dropout rates in general. In one RCT with a higher retention rate, there was 80 patients with amphetamine dependence that were randomized to 12 weeks of oral daily naltrexone or placebo. Overall, 69% completed this trial with no difference in retention between the treatment arms. And in the intention to treat analysis, the naltrexone group had a significantly higher number of amphetamine negative urine samples compared with placebo, 65% in the naltrexone group versus 48% in placebo arm. There was also a significant reduction in self-reported craving levels and consumption of amphetamine in the naltrexone group compared with placebo. As you can observe, however, the mean number of negative urine samples became lower over time for both treatment groups. And very notably, the authors excluded patients that could not maintain abstinence for 2 weeks prior to enrollment in the study. So the result was that 214 of 294 persons that were approached for the study were actually excluded. So clearly there's some selection bias that may have contributed to retention and outcomes. Next slide. In another randomized controlled trial of 100 patients with amphetamine dependence, patients received 6 monthly doses of long-acting naltrexone or matching placebo after varying lengths of inpatient treatment and the transition to outpatient therapy. Retention in either arm was only around 50% in the study, and long-acting naltrexone had no effect on amphetamine positive tests in the study. And then finally, in a third randomized placebo-controlled crossover lab study, 30 non-treatment seeking individuals with meth abuse or dependence completed 2 inpatient stays where they were assessed for cue-induced cravings after receiving oral daily naltrexone versus placebo. And naltrexone was found to decrease overall subjective ratings of drug craving compared with placebo in response to cues in this small study. Next slide. So the ADAPT-2 trial again looked at the combination of long-acting naltrexone with a higher dose bupropion than had been used in previous studies mentioned, 450 milligrams as opposed to 300 milligrams daily. Next slide. So it included 403 subjects at 8 different clinical sites from 2017 to 2019. It was a double-blind randomized placebo-controlled study, and it had a sequential parallel comparison design. Next slide. I'm not going to go into this, but I can answer questions about it later. This is basically a slide on sequential parallel comparison design because it was a study design that I was not personally familiar with, but I can go over that in later when we answer questions if someone has questions about that. Next slide. And next slide. So eligible study participants were adults who met DSM criteria for moderate or severe methamphetamine use disorder and notably had to be opioid-free at the time of randomization based on a urine drug screen. Next slide. The primary outcome in this study was the percent of subjects with a treatment response, which was defined not by abstinence in this study, but by having at least 3 out of 4 negative urine drug screens in the last 2 weeks of a 6-week treatment program. Next slide. Around 400 participants underwent randomization. Around 100 were assigned to receive naltrexone bupropion combo, and around 300 received placebo. The average age was 41. Nearly 70% of subjects were male and white. Next slide. Response rates were 14% with naltrexone bupropion and 3% with placebo, for an overall 11 percentage point treatment effect, which was significant in the intention to treat analysis. The number needed to treat for this reduction in methamphetamine use was 9 subjects. Secondary outcomes such as methamphetamine craving scores also favored the treatment group. Next slide. There were significantly more GI adverse events, which were most commonly nausea, that were reported in the naltrexone bupropion group, and at fairly high rates of about 30 to 40% compared to 15% in the placebo arm. Serious adverse events occurred in 8 of 223 participants who were on naltrexone bupropion. Next slide. The authors concluded that among adults with methamphetamine use disorder, there was a low but significant response to extended release injectable naltrexone plus oral bupropion over 6 weeks. Next slide. So in terms of the strengths of the study, in a pretty barren landscape, this certainly appears to at least be a safe option that could be helpful for patients, as long as they can tolerate the GI side effects. This study also did include a large subset of people with severe methamphetamine use disorder. Next slide. In terms of shortcomings, the vast majority of people still did not appear to have the desired treatment effect with bupropion and naltrexone. And of note, in this study, about 75% of those randomized to naltrexone bupropion were actually adherent in the study, which is higher than with mirtazapine and a lot of other studied treatments. While in this study, adherence to oral bupropion was measured by self-report and pill count, and not plasma or urine drug levels. In terms of other limitations, this study, like others, is likely to have strong selection bias, especially when participants had to agree to biweekly urine drug screens. Longer term outcomes are unknown. There was a lower representation of women in this trial. And then concurrent use of opiates is also contraindicated with naltrexone treatment, while this is commonly an issue that we see. And so starting this treatment option in the absence of point of care testing, and also specifically for fentanyl, would not be recommended, as it would precipitate withdrawal. Next slide. So in summary, while we clearly need more efficacious treatments, there are safe and potentially helpful options that I believe warrant consideration for persons with struggling with methamphetamine use disorder. And just as an anecdote, in fact, I was surprised that the majority of my own patients who have tried bupropion and naltrexone for methamphetamine use disorder have specifically reported subjective improvement in cravings. I also have a patient who has benefited from mirtazapine. In the future, aside from the incredibly exciting new treatments like monoclonal antibodies in the pipeline, we could use more information about the impact of combining existing medications with evidence-based psychosocial interventions, such as contingency management and cognitive behavioral therapy. And I'm going to turn it over to Dr. Montoya now to discuss behavioral interventions.
Great, thank you all. And so as Dr. Rajagopal just mentioned, I'll be presenting on non-pharmacological treatments for methamphetamine use disorder. I'm sure some people in today's participant list are familiar with these, but I really just want to go over today the principles of treatment of methamphetamine use disorder, speak to the research that supports these non-pharmacological treatments for meth use disorder, orient people to what these treatments consist of, and then some practical implementation considerations. So next slide. So these principles of methamphetamine use disorder treatment are derived from the National Institute of Drug Abuse. There are actually 13 principles of substance use disorder treatment, but I'm pulling here the 6 that I think are most salient that I want to highlight. So the first is recognition that methamphetamine use disorder is complex, but it is treatable. As I think Dr. Raja Kapal did a nice job illustrating, no single treatment is appropriate for everyone. Some people will respond to medication-assisted treatments offered on their own. Some people will respond to behavioral treatments offered on their own, and others may really benefit from a combination of the two. What we do also know is that treatment needs to be readily available. So people's circumstances change, their motivation change, and the longer treatment is delayed, the more likely that we'll have difficulty following up with people and getting them connected to treatment. So as best as we can know what treatments exist and are available to the patients, I think the better off we are. And then if a pharmacological treatment is offered, it is thought to be best practices to combine it with a behavioral treatment. So I'll be speaking to what those behavioral treatments are for methamphetamine use disorder. And remaining in treatment for an adequate period of time is critical. So when we're thinking about behavioral interventions, that is typically a 3-month period, if not longer. And then for pharmacological treatments, that's typically about 12 months. And then the last principle I want to highlight is that ongoing monitoring of methamphetamine use is critical. This can be through urine drug screens. This can also be through self-report. But the reason why we want to do this is that patients can really benefit from the accountability, and it really helps us adjust the treatment plan. So if someone is struggling with lapses or relapses, it allows us to really dive in and see if there are other treatment approaches that we can adopt, or if we really do need to facilitate additional practice of behavioral treatment skills. On the left-hand side on the slide here, I do have a theoretical path to recovery from methamphetamine use disorder. And I typically do show something like this to our patients in the cognitive behavioral therapy group. And the reason I do this is often people, patients who are struggling with meth use, as well as their family members, have this expectation that recovery will be a pretty static process where once they engage in treatment, they should really just be seeing positive change. And that can be the case for some people, but often the case, people do experience lapses, which are brief moments of returning to use, but then quickly going back to positive change, or relapses where someone might get in the spiral of using methamphetamine for a longer period of time. And if we were to focus on kind of those lows, I think it really shortchanges people because progress has been made and they have learned new skills along the way. And if we take a bird's eye view, we can see that change is happening and that the path to recovery is dynamic and involves many opportunities to learn and to make more positive change along the way. So next slide. So today I'm going to highlight 2 non-pharmacological treatments that are recognized by the National Institute of Drug Abuse as being the most effective treatments for methamphetamine use disorder. So those 2 are contingency management and cognitive behavioral therapy. Next slide. And so on the slide, I am showing the results of a recent systematic review that was published in 2020 that looked at all the various trials for people in recovery for methamphetamine use disorder. And so this systematic review was actually quite larger. It looked at other behavioral treatments beyond contingency management and cognitive behavioral therapy, but I'm pulling out the data related to contingency management and cognitive behavioral therapy because the systematic review did show that these indeed were the most effective treatment modalities. When you look across various different outcomes, so the ways in which methamphetamine use disorder outcomes have been conceptualized in these 16 different trials is either having a greater number of meth-free urine samples, having more consecutive days of not using meth, as well as outcomes such as treatment attendance. And what they see is that contingency management and cognitive behavioral therapy are quite comparable, and contingency management tends to be more effective the longer that it is provided, with one study showing the 4-month mark being kind of an optimal duration. And then with cognitive behavioral therapy, we do see that it is more effective when it is tailored to the patient population that you're working with. There was that PEC 2005 study that did show that the combination of cognitive behavioral therapy and contingency management resulted in greater treatment attendance over time, compared to CBT that only saw about 40% of people showing up to the treatment sessions. And then there is a signal that the combination of contingency management and cognitive behavioral therapy yields the best outcomes across these 16 different studies. Next slide. And so I am presenting here data from a trial that was published back in 2005. So this is conducted quite some time ago, but I think it nicely illustrates what has been found in other similar studies. So this study involved 4 different treatment arms. In the blue, the light blue, you have cognitive behavioral therapy, which was just a standard version. In the darker blue, we have a cognitive behavioral therapy intervention that was tailored for men who have sex with men. In the dark green is contingency management. And in the lighter green, we have the combination of contingency management and cognitive behavioral therapy. For this study, the outcome was treatment effectiveness score, which represented the average number of urine samples provided by condition that were free of methamphetamine. And what we see here is that the different arms were quite comparable, except for the non-tailored cognitive behavioral therapy tended to do slightly worse than the other treatment arms. Next slide. And then the last research study that I want to show today is in regard to the duration of treatment. So one of the principles I highlighted in a previous slides was that the duration of substance use treatment matters. And so when we're thinking about behavioral treatments, really the gold standard is at least 3 months. In this study, they tested 3 different contingency management conditions. So in one arm, people received contingency management for 1 month. In another, they received it for 2 months. And then in a third, they received it for 4 months. And this was compared to treatment as usual. And then they had 2 different outcomes, which was days of longest abstinence, as well as the percent of patients with negative urine screens for methamphetamine. And what we see is that the 4-month contingency management trial, or arm rather, resulted in better outcomes. Next slide. So now I'm going to speak about the actual components of these 2 different interventions. And I'm going to start first with contingency management. So typically in contingency management, we collect sample from participants 2 to 3 times per week. And typically this is a urine sample to test for the presence of methamphetamine. And there are different protocols associated with contingency management. There's a voucher-based protocol and a prize-based protocol. But what these refer to is just the way in which people are given positive reinforcements for having meth-free samples. So patients receive a positive reinforcement on an escalating scale for consecutive meth-free samples. So in the example of the fishbowl method, the first time they have a urine sample that is free of meth, they may be able to select 1 slip from this fishbowl. And this fishbowl contains 500 cards, with 50% of them associated with a prize. So 50% of them have some sort of positive affirming messages. 204 of them have small prizes that are worth about $1 in value. 45 are large prizes, typically about $20 in value. And there's typically 1 jumbo prize worth $100. So they're able to draw 1 slip that first time they have a meth-free sample. And then if they come the next time and they also have a meth-free sample, then they get to draw twice from the bowl. And this kind of goes up in scale, typically until they reach 8 draws, and that they kind of max out there. If they have a meth positive or unexcused sample, that resets them in the reinforcement schedule. So they go back to having one slip or one draw rather, per meth negative, and then they work their way up. There's typically a rapid reset, which typically once they've established having 3 meth-free samples, they can return to where they were in their reinforcement schedule. And that's done so it's not punitive. And typically people using the prize-based procedure can receive rewards up to $250 to $400. Next slide. So some principles of contingency management. So here we are offering positive reinforcements for meth abstinence. And one thing to think about when implementing contingency management is most trials have really shown the effect of targeting one single behavior. I think a lot of times people tend to get really excited about how effective contingency management is and want to apply it to a lot of different behaviors or various different substances. But it is really best practices to identify a single behavior you're targeting and to reinforce that behavior. And so in the context of methamphetamine use disorder recovery, one behavior might be meth abstinence as indicated by a negative urine screen. But if urine screens for some reason aren't available, then another target behavior that could be reinforced is attendance to treatment. It's also important that positive reinforcement occurs immediately after the desired behavior. This facilitates learning, and often when the positive reinforcement is delayed, people may not learn that staying free from abstinence means I get this incentive. So it's very important to pair those as closely together as possible. It is also crucial that the positive reinforcement is valuable to the person who is trying to earn it, and that escalation is important. So this is illustrated by having multiple draws from that fishbowl. And then I also want to mention that compared to punishments, positive reinforcers encourage positive expectations and emphasize people's accomplishments in recovery rather than their shortcomings. Next slide. So some practical implementations for offering contingency management. Some strengths are its established efficacy, especially for methamphetamine use disorder. You can target a very specific behavior that you're trying to help change. It can be delivered by non-specialists, so you don't need someone with a fancy degree to offer it. And the clinic visits associated with contingency management are very brief. So it typically involves no more than a sample collection and then the delivery of the incentive if earned. Some weaknesses of contingency management is that it typically does involve people coming to clinic 2 to 3 times per week. And there is a lot of burden associated with that in terms of the commute time to a clinic and the transportation cost. There is also a need currently to identify a funding source to cover the cost of reinforcements. Oftentimes this is in the form of some sort of grant mechanism. And then once you actually do have the funds to be able to deliver contingency management, there is a need to develop an accounting process for tracking the distribution of those reinforcements. And then lastly, it does require having a large supply of urine screens if you decide to target meth abstinence as measured through urine testing. Next slide. And then I'm going to give a brief primer of what we mean by cognitive behavioral therapy. In cognitive behavioral therapy, patients are learning the interrelationships between their thoughts, or in other words, what they tell themselves, their feelings, such as their emotions or physical sensations, and their behaviors. And typically this is focused on meth use behaviors. We also acknowledge that the environment does have a significant influence on our thoughts, our feelings, and our behaviors. We typically, I tell patients, can't directly target feelings, So if someone is struggling with anxiety or depression, the best way for us to improve someone's mood is by changing their behaviors, what they do, and their perspective. So typically in our cognitive behavioral therapy sessions at Owen Clinic, we start off with the behaviors, teaching people behavioral coping strategies that can be used when they experience an urge to use, as well as reducing their vulnerability to experiencing urges in the first place. We focus on behavioral activation, which is getting people to engage in other behaviors than methamphetamine use. And then we also target thoughts. Next slide. So here is a summary of some of the behavioral skills that are covered in our cognitive behavioral therapy sessions. So some of them focus on changing the environment, such as leaving situations or staying away from triggers. Again, I mentioned behavioral activation. So this involves helping people identify pleasant activities. Oftentimes people have forgotten what they enjoy doing beyond methamphetamine use, or they never were able to develop hobbies. And so it's getting people to try out new activities that are healthier for their mood and physical health. There's an emphasis on taking care of physical health, so getting adequate sleep, eating healthy, taking prescribed medications. And then we also borrow some skills from dialectical behavior therapy, such as the stop skill, the pros and cons, as well as breathing exercises. And then we also do things like paired muscle relaxation and grounding exercises, and really help people build a network that is supportive of their recovery. Next slide. And then the cognitive skills, we typically introduce midway through our CBT groups. And so in this instance, we're helping people first be able to identify what are some of the thoughts that they experience in the first place. And we do this through the use of ABC worksheets for people to identify an activating event that often leads to them using methamphetamine. So in this example, this person writes, "My partner and I got into another fight about my recent meth use." And this results in them having the thoughts, "I will never get better." And consequently, they feel hopeless and end up using again. So what we teach is kind of the step 2, which is how do you check that thought, "I will never get better." So we have participants identify all the evidence for that belief. And in this case, this person has been in treatment 4 times, and they're still struggling in their recovery. And the evidence against this belief, "I will never get better," is that they have been practicing skills and have been going longer periods of not using meth. And it is possible for them to get better. So they were able to identify that this belief is not 100% accurate, and it's also not helpful for their recovery goals. And so in step 3 of cognitive skills, we teach people how to develop more accurate and helpful ways of thinking. And so the resulting belief here is, even though I feel frustrated right now, I can recover. Next slide. So some implementation considerations for cognitive behavioral therapy, similar to contingency management, it does have established efficacy, especially when you tailor it to your patient population. One thing that I didn't mention based on research is that it has shown to have durability of effects beyond the active treatment condition. This is often referred to as the sleeper effect. So with CBT, what we see is that a lot of the progress and positive changes that people make while participating in cognitive behavioral therapy tend to even be reflected a year out. Another strength is that there are a lot of manuals that exist for cognitive behavioral therapy, and that it is transdiagnostic. And what I mean by that is while you're working on targeting people's methamphetamine use, you are able also to address issues of mood like depression and anxiety. Weaknesses of cognitive behavioral therapy is that it typically does involve extensive staff training. At the Owen Clinic, we do have group supervision, so we can make sure that people who are delivering cognitive behavioral therapy feel like they have the qualifications and the training to do so. It can be comparatively demanding on patients compared to contingency management, especially those who may have issues related to cognitive impairment. It will say clinician fidelity to cognitive behavioral therapy does vary, as well as the manuals. I think it's important to stay up to date on kind of the most recent researched cognitive behavioral therapy approaches, but that isn't typically always done in every single setting. Next slide. So to summarize, non-pharmacological treatments are the gold standard approach for treating methamphetamine use disorder. And these, with the most effective research base behind them, are contingency management and cognitive behavioral therapy. And I also want to mention that each treatment does have specific implementation considerations. And so that will dictate what you're able to offer. All right, so now I'm going to turn it over to our behavioral health counselor and recovery specialist, Brene and Damon.
Good morning. Hi, my name is Brene Justice Royster, and I am the behavioral health counselor at Owen Clinic. I've been with UCSD for a little over 12 years, and with the Owen Clinic, a little over 7.5 of those years. And over that time, I've had the honor and the pleasure of being able to work with some amazing individuals, helping them on their journey of recovery. Today, I'm going to be sharing testimonials of 2 individuals I have worked with over this time. And the first testimonial I will be sharing is someone that I've worked with medication-assisted treatment. And the second testimonial will be from an individual that has participated in contingency management and cognitive behavioral therapy. So the first individual is a 42-year-old college-educated Hispanic male. He said he would like you to know, I would like to share a little bit about my story, in particular, my 7-year struggle to get sober and off crystal methamphetamine. Like I mentioned, I have had a really hard struggle with addiction. I am by all means a very smart and capable man. I have put myself through college. I have 2 degrees, both in fashion design and the business of and marketing of. I did not start using drugs until I was 35 years old. Over the next 7 years, I saw myself lose my partner of 11 years, our beautiful home on a golf course. I burned all my bridges in the fashion industry, lost my car, and eventually ended up homeless on the literal streets several times. I did things I would never have imagined doing, like selling my body, shoplifting, and endless abusive relationships just to feed my crystal meth habit. A little over a year ago, I reached what I hoped to be my ultimate rock bottom. I was in the most physically and mentally abusive relationship of my life. I lost my father to COVID, my partner to fentanyl overdose, and then my best friend to the same. I realized at this point, I would do anything to gain control of my life. I went to rehab, and while I was doing my required physical exam to be accepted into rehab, I was introduced to Meth services. I was desperate to do anything and everything to change my life, so I agreed to try Vivitrol. The results were almost immediate. Within a couple of days, I found that the mental obsession had calmed. I was able to then work a very honest and thorough recovery program along with therapy. I even fought to get 2 extra month-long extension in rehab, which is something I would never do. Additionally, I could never accumulate more than 2 to 3 maybe months of sobriety before Vivitrol. Remarkably, the Vivitrol had a surprising effect on other parts of my life. I had struggled with eating disorders since I was 9, bulimia to be exact. And every time I entered a program, mind you, 16 times, as soon as I put on weight, my brain would just go crazy and tell me to throw it up. This time, I was able to be rational and tell myself things like, it's only temporary, and my body needs it, or I can address this at a later time. To end, it will be 1 year off substances on September 3rd. I could not be happier or healthier. I stopped using Vivitrol about 3 or so months ago, and everything has been going well. Recently, I find that I'm dealing with a lot of outside issues, like my father's estate and my work closing down, so I fear the stress might take me out. I'm determined to not repeat the past, so I will be going back on the Vivitrol injections because I know that it will definitely help me through this tough time. I also would like to say that all this has been made possible because of my amazing team of doctors, nurses, and counselors at the Owen Clinic. They have been with me from the very start of this journey 7 years ago. They have gone out of their way to assist me in any way possible. I am in such gratitude to them and all of their hard work, support, and kindness. So that was from the person that participated in MAT treatment, and he's doing very well. Now, the second letter is an individual that participated in contingency management and cognitive behavioral therapy groups. 59-year-old college-educated white male living with HIV, history of ADD, anxiety and depression, unemployed for past 4 years. I don't know why I started using meth roughly 5 years ago. However, this study came along just in time for me to seriously stop, walk away from the party, and move on with my life. I have always known that meth use is inconsistent with my life goals, but literally nothing else matters when using. The seriousness of the wreckage from inattention to my own life that slowly but insidiously added up did not become apparent until I was waist deep in it. My occasional social use was not going to remain a secret much longer, as the dance along the cliff top brought me closer to personal disaster. I have had several moments of clarity and put it aside for a couple of months at a time. I could clearly see I wanted to stop and move on. However, I did not actually move on when I stopped. The CBT group worked for me because I have been actually putting my skills, knowledge to relative consistent use now in each instant when I think of it in the present. Applying the CBT to get through negative situations as well as help me build my positive experiences makes a difference. My inner monologue is rather intense, as it is easy for me to get lost or forget my path within my head. When I take micro steps, the understanding of the interrelational of my thoughts, feelings, and actions is easier. I have been using the tools to keep taking action, no matter how small, forward, and that helps me to see that meth use is just a meaningless trap for me. Importantly, my life is actually pretty great, and I have a tremendous amount to enjoy today. An authentic life is hard, but it is worth it. When I feel overwhelmed, my ingrained behavior has been to freeze and avoid. When I can identify this, sort out incorrect thoughts, assumptions, and notice my emotions, it is easier to take any small positive action forward and then another. I have been doing this with somewhat remarkable success so far. The relationship with my husband improving with my tangible actions. I am successfully interviewing for a $150,000 job. I am feeling better about entering and enjoying the next phase of my life. I am willing to do the work, let go of my personal inner BS, and enjoy actively and proactively the beautiful imperfections that is my life. Thank you. I will now turn it over to our amazing recovery specialist, Damon Robinson. Damon, you are on mute. Damon.
So Dr. Bamford, do you, is Damon with you, or are you there, Damon? Okay, we just can't hear you.
There you go. Are we good now?
There, perfect.
Okay, good morning,
We're-
everyone. Sorry about that. We were having difficulties this morning and I thought it was gonna work, but it didn't. So thank God I'm right next door to Dr. Bamford. So,
No worries. We're happy you were able to.
Okay. Great. My name is Damon Robinson. I am the new kid on the block here at UCSD. I've been here almost about 4 months now. Not new to the field of recovery. I've been a substance abuse counselor now for almost 8 years. I was the intake coordinator over at Stepping Stones for almost 8 years. And I was also their sober living manager over there for all 3 of the sober livings. And I was recruited here to UCSD, where I absolutely love. And I've had the opportunity of working with some of the patients here that I work with now are some of the same patients that I've worked with over at Stepping Stones. So this one particular person that I worked with over at Stepping Stone, he's also here at UCSD, and he's in the MAP program here. So I've worked with this patient for over, I would say about 6 years now, and off and on, getting him in and out of treatment and just trying to help him as much as I possibly could. And I've noticed how much his life has changed since he's been on the MAP program. So he sent me over a little letter and he wanted me to read this letter to you. He's a 35-year-old Mexican male, Latino male, and he wanted me to read the letter. And it goes, I am a participant at the Owens Clinic, at the UCSD Owens Clinic for the later part of 2012 to onward. As of November of 2021, when I re-embarked on the path of recovery, I checked into Stepping Stone's residential program to work on my issues with drug and alcohol. There I began to foster more healthy lifestyle dealing with mental, physically, and emotional damage I caused to myself due to years of drug abuse and risky behavior I engaged in. Getting sober was the best decision I made for myself, seeing that I had been living with a dangerous lifestyle in the last 6 years, watching close friends of mine lose their lives to the dangers of addiction. Desperately, I wanted to succeed and eliminate substances from my life. As of November of 2021, I've had a daily medication regimen that included 450 milligrams of Wellbutrin. I have also incorporated the med conjunction with the routine Vivitrol injection suggested by the MAP program to keep my physical craving substance low, which I feel is working great. I have been on the MAP program since November of 2021 and been doing a great job. Dr. Grillotti and the staff have been a great help to me through the period and have spent a great deal of energy and time to make sure I stayed sober in the most successful and comfortable way possibly. I have been active, productive, and esteemed person now than I can remember. I stay connected to the recovery community, and I am of service as much as possible. I am now back at City College as a full-time student. I exercise daily. I have dramatically cut down on my cigarette smoking intake, and I definitely live a more healthy lifestyle today. I feel great and plan on committing to the MAP program for as long as I feel it benefits from it. Its services help me as well as others who I've conversated with about. This is a client who has struggled with addiction for years. He's been in and out. I think I intaked him in Stepping Stones about 5 times. And he's currently at the Sober Living and doing amazing. I mean, really amazing. So I love what I do over here at UCSD. I love the MAP program. It's changing lives. So.
Thank you.